Hi guys, welcome back to Codemaster Coach, your medical coding tutor. As promised, we're continuing our studies on risk adjustment. And if you're questioning why we're doing an in-depth study on risk adjustment, just know that companies now are looking for coders that can do risk adjustment. So if you haven't paid much attention, go back and review my previous 3 videos on risk adjustment. This is a continuation. Follow along with me. As I ended the last video, I promised you a checklist that's used by CMS. So let me share that checklist with you. Okay. All right, as you can see here, this is the Center for Medicare and Medicaid Services Adjustment, it's Risk Adjustment Data Validation Medical Record Checklist and Guidance. Now notice it says that this checklist was provided to plans involved in calendar year 2009 and 2010. But when I checked the CMS website, this is the same checklist that is still up to date. Now this list may help to determine a record's suitability for risk adjustment, data validation, and any item checked no may indicate that the record is not or does not support the CMS HCCs. So look at the questions that you're going to audit. Is the record for the current enrollee? Is the record from the current calendar year for the payment year being audited? In other words, for audits of 2011 payment validating records should be from the calendar year of 2010. Is the date of service present on the face-to-face visit? Is the record legible? Is the record from a valid provider type? Hospital, inpatient, hospital, outpatient, and physician. Are there valid credentials and/or is there a valid physician specialty documented on the record? Does the record contain signatures from an acceptable type of physician specialist? Because notice only certain types of physicians can do risk adjustment, right? And if the outpatient physician's record does not contain a valid credential and/or signature, is there a complete CMS generated attestation for this date of service? Is there a diagnosis on the record? Does the diagnosis support an HCC? And does the diagnosis support the requested HCC? So again, these 11 questions. And it says CMS published a risk adjustment data validation checklist, which is this form, to assist auditors who are reviewing charts for Medicare Advantage validation audits. This checklist also offers guidance to Medicare Advantage coders because the goal of any coder should be to abstract correctly and within the rules of payer organizations responsible for paying the claims. A Medicare Advantage record that passes a risk adjustment data validation checklist requirements will presumably succeed in a real risk adjustment data validation. 8 of the 11 items in the risk adjustment data validation checklist identify administrative errors that are often caused for failure of these risk adjustment data validations. An administrative review of the chart is always the starting point because it is better to reject a chart before investing too much time coding it. So again, a lot of these questions are administrative, where you're just looking to see if it's legible, if it's there. Okay? So again, this is the CMS Medicare Medicaid Services Risk Adjustment Data Validation Medical Record Checklist and Guidance. All right, so what are the Medicare rules? The Medicare rules are that the date of service must be documented. The encounter must be signed by the provider of services. The provider of services must be a specialty type that is acceptable for risk adjustment. The documentation must be legible and acceptable. The patient must be for an enrollee in the program during the dates of service. As far as the medical record, coders must abstract from the medical record the diagnoses pertinent to today's encounter, and the record must be authenticated by the treating provider, and the date of service must be identified. The patient's name and demographics, the name linked to the patient's Medicare enrollment. This name must be verbatim. The patient's date of birth. Coders must verify the integrity of the patient's identity. For dates of service, date of service is the date or the range of dates during which the patient received the described care. Dates of service is usually a face-to-face visit, but may also be a telemedicine visit. CMS signature requirements. It must be a legible full signature or a legible first initial and last name. If illegible, signature over a typed or printed name. Illegible signature where the letterhead, addressograph, or other information on the page indicates the identity of the signatory. Illegible signature not over a typed printed name and not on letterhead must be submitted. Documentation is accompanied by a signature log or an attestation statement, or an initial over a typed or printed name. Initial not over a typed or printed name, but accompanied by a signature log or an attestation statement. So what is attestation? Formal signature or a formal statement asserting that a specific medical record, while not authenticated sufficiently by the physician at the time of care, is authentic. An attestation must be signed by the author of the initial or the original record. Attestations are valuable if the physician has not authenticated a record and the record is being audited. Inpatient records. There are very few differences in inpatient and outpatient coding except rule-out diagnoses in a discharge summary may be coded as if they were proven for an inpatient record. And a properly authenticated discharge summary is key to coding inpatient records for risk adjustment. Without the discharge summary, the entire chart must be coded as if each encounter were separate rather than as a hospitalization for a range of dates. Who are the acceptable providers for risk adjustment? Providers must be directing the evaluation or treatment of a patient. And I did find a document that helps us to know. And it says here, let's see if I can enlarge that for you. Okay, it says provider type hospital, inpatient, and then covered facilities include short-term, general, and specialty hospitals, religious, non-medical healthcare institutions, long-term hospitals, rehab hospitals, children's hospitals, psychiatric hospitals, and medical assistance facilities or critical access hospitals. Now, non-covered facilities include skilled nursing facilities, hospital inpatient swing bed components, intermediate care facilities, respite care, and hospice. These are non-covered facilities. All right, continuing. Document source. An unacceptable document source. Anything signed by an unacceptable source, example, nurse's notes in an inpatient chart or laboratory report, MSDRG summary in an inpatient chart, patient transfer orders in an inpatient chart, ambulance notes, and super bills. These are all unacceptable document sources. With the exceptions when guidance allows documentation from unacceptable providers, when the radiologist report provides more granularity to the treating physician's diagnoses while not contradicting. For example, it's adding more specificity to the fracture diagnoses. Based on that radiology report or that radiologist report, it will describe exactly what type of fracture. In that case, it would be acceptable. Problem list and medication list, usually carried forward from a previous encounter, documented in the electronic health record. These tend to be difficult to authenticate as part of the current encounter, and it may include resolved or worsening conditions, and CMS doesn't always accept the codes abstracting from a problem or medication list. Now, when it comes to EHR, the specific issues are signatures, cloning, and within a single patient record and amongst a group of patients, or altering the text of it. So those are some issues with the electronic health record. Sharing access passwords with electronic health records. All right, guys, in my next video for risk adjustment, I'll be covering chart components. All right, guys, that's it. Thanks. I'll see you in the next one.